Welcome, and thank you for tuning in to Derm Docs, powered by LiveDerm. This marks the final episode of a two-part educational series to raise awareness of Epidermolysis Bullosa, EB, and the latest FDA-approved treatment options for this disease. Our host, Dr. Michael Lavery, a pediatric dermatologist and clinical assistant professor at the University of Florida in Gainesville, Florida, is joined today by Dr. Joyce Teng, professor of dermatology and pediatrics at Stanford University School of Medicine in Stanford, California, as they discuss the evolving treatment landscape for epidermolysis bullosa patients.
Welcome, listeners, to part 2 of this exciting educational activity on epidermolysis bullosa. I'm Dr. Michael Lavery. I'm a clinical assistant professor at the University of Florida. I'm a pediatric dermatologist and have an interest in EB and chronic itch. I am joined today by my colleague, Dr. Joyce Teng, who will join me in discussing the treatment landscape of EB, as well as some practical pearls for implementation in clinical practice. Dr. Teng, it's a pleasure to have you back for part 2 of this podcast program. Can you please introduce yourself for our listeners?
Thank you, Michael. I am Dr. Joyce Teng, professor of dermatology and pediatrics at Stanford University School of Medicine. I've been taking care of EB patients for more than 18 years, and my main interest is in therapy in rare genetic skin diseases.
All right. It's a pleasure to have you here. So we're going to start talking about EB and treatment. So when you have a patient with EB in your practice, what steps do you take prior to considering the treatment plan? If you could walk us through your process.
Dr. Lavery, in part 1, you have mentioned there are many different subtypes of epidermolysis bullosa, simplex, junctional, and dystrophic epidermolysis bullosa. And the genetic underpinning for these different subtypes of EB are very different. And if we just based on clinical presentation and symptoms, especially during infancy and early childhood, sometimes it can be deceiving. And even EB simplex can mimic the most severe type of dystrophic EB. Of course, the prognosis and management are very different. And so it is important for us to know which subtype of EB the patient has in order to do it timely and accurately. I'm sure many families and parents would also love to have those information as early as possible. Currently, the most accurate test and fastest test almost is genetic diagnosis. And many different genetic companies, genetic testing companies have panel testing can help us make the accurate diagnosis earlier. However, we recognize that genetic testing is not always available in other parts of the world and in certain area. So a skin biopsy is still available and is still being utilized. And the skin biopsy can be processed differently. Dermatopathologists who are most experienced in making those diagnoses, sometimes using special technique such as immunofluorescence, electronic microscopy to help make the diagnosis and separate different type of EB. But as you mentioned early, that genetic testing is getting much more accessible, and it doesn't have to be as invasive. It doesn't even have to involve a blood draw. It can be just a sputum and a buccal swab and mail it to some of these companies.
Yeah, I agree. We're very fortunate in the U.S. that we're able to have this. But as you mentioned, skin biopsy is still available, also processed for other places in the world. Whenever you then have genetic confirmation of EP, what are the goals of therapy when treating individuals with EP? How do you plan to involve either the patient or the caregiver in trying to identify the setting and kind of measuring those goals?
Yeah. Actually, let me go back to second part of your previous question in regard to severity assessment. I think many of these therapeutic and managed goals are directly associated with patients' severity as well. So for each different subtype of EB, the manifestations are a little different. So let's begin with the most severe type of a dystrophic EB patient. For instance, early on during their infancy, blistering, maintaining their nutritional status, and maintain body temperature, prevent infection, are some of our main objectives during that acute phase. And because early on, we skin fragility is our primary challenge. As time goes on, patient will start to experience damages on the skin and damages to their other organ system as well. As we discussed early on, there may be manifestation scarring of the cornea affecting the eye, esophagus, and trouble swelling. And some patients may need a supplemental nutrition and by having the G-tube placement. And, fusion of their digit to affect their ability of walking. And they may have issue with bone density from chronic illness and lots of pain and itching and scarring. And also that these chronic disease also lead to manifestation of internal organ systems, such as severe anemia, iron deficiency, and due to that, they may also have a cardiovascular manifestations, and their heart, and due to the anemia over time, may not be able to handle fluid in the body as well, and kidney problems, and all of these things. So the treatment goal is a moving target, really depending on how severe the disease manifestation for each of these organ systems, and how we can. But overall, our goal is minimize skin injury, reduce damage, and also, for adults, especially early detection of or prevention of the skin malignancy is another goal as well. Because this is a chronic disease, a lifetime disorder. And, we very much are focusing on the impact of this disease on patients' quality of life. And we're focusing on the impact not just on the patients themselves, but also on parents and family. So we talked about the care structure, the infrastructure that we have at these multidisciplinary clinics. We have not only medical specialists, but also social support, from our social workers and other supportive system to help our patients adapt to their or integrate into school and integrate to their a peer network and help them to be as independent as possible. So I would just say that, that's a kind of like an overarching goal that we're trying to achieve. Of course, there are a lot of details and nuance to each one of these areas.
That's a great summary of the goals of therapy. I have an interest in itch, and so I often go into detail about how the itch affects them, how they describe the itch, which is obviously difficult in smaller kids, the severity, which parts of their skin are kind of more itchy than others, and then trying to treat just the itch, that, as you know, is very challenging, especially when a lot of these treatments are either difficult to get or sometimes, dosing can be difficult and challenging for small babies. But I agree that the therapy includes all of that, and the gold standard is still skincare with, non-adhesive dressings and bandages, etc. But of course, as you know, we now have 2 FDA-approved therapies, which is really very exciting. We have both been doing this for long enough where there wasn't anything approved, and now suddenly we have 2. So can you give us a brief overview of the different therapies that are currently approved by the FDA for the treatment of EB?
Yeah, absolutely. And that's the most exciting part of our work as well. For many years, and I've taken care of patients with rare genetic disorders, and in addition to EB as well. And many times, we understand what is the cause, what is the gene, and this is also why in the past, at least when I was doing my training, and parents and families, and they may or may not be interested in doing genetic testing and some of these diagnostic testing, because they feel like it does not change the patient's care, and we offer a lot of supportive care, but there wasn't anything to address the underlying cause, and finally technology has caught on with the diagnostic testing. And now, for EB, we're looking at therapy that addressing wound healing, wound care directly, reduce inflammation, speed up wound healing. And we have more targeted therapy to use either gene-directed treatment or protein and cell therapy. So it is a really exciting era to have all of these scientific and technological platforms to target specific genetic disorders. So the 2 therapy FDA approved specifically for EB for the last few years. First one that was approved was a gene therapy using a viral vector, and it's also known as a BVAC. And as you know, majority of dystrophic EB patients carry the genetic mutation in the collagen 7 gene. For those that who are not terribly familiar with the skin anatomy, collagen 7 form a triple helix together, and it's like a robe tying the epidermis, the superficial layer of the skin, anchoring to the deeper layer, the dermis of the skin. So it is a very critical mechanical structure that contribute to the integrity and mechanical strength of the skin. So the dystrophic EB patients, because it is a monogenetic disorder that affecting the collagen 7, and it is a very clever way to design and putting a normal copy of the collagen 7 gene onto a very common viral vector, HSV, herpes simplex viral vector, and it can be applied directly on the skin surface and deliver the gene into the cell itself, and using the human cell keratinocytes or a fibroblast to make the collagen 7 protein, and these collagen 7 protein that produce on the skin surface, and then forming the structure to enhance the mechanical strength. The second therapy FDA approved is a birch triterpene extract from plants, and so it's natural, and this extract is compounded into sunflower seed oil, very, very gentle on the skin surface. EB wound is very sensitive, has significant itch and pain. So the vehicle is just as important as the active medication itself. So this treatment is a topical application on EB wound. Currently, the mechanism of action for this particular therapy is not completely clear. However, it did meet all the primary endpoints, and as well as some of the secondary endpoints in clinical trials, and that it helps with improving EB wound, faster closure, and reducing some of the associated symptoms, such as dressing change, pain, and itch that we have mentioned earlier.
That's a really great summary of the treatments that are available. As you mentioned, the first treatment FDA approved in May 2023, and then birch triterpenes in December 2023. So we now have two FDA treatment therapies for EB. What are some of the treatment considerations when deciding how to approach the different therapies that are available?
When it comes to choice of a treatment, and I try to prioritize the patient's need and see whether, we obviously try supportive care first, and using those non-sticking dressing, silicone-based dressing, and sometimes when they have some bacteria, and you can use a certain type of a dressing with the additives on it to decolonize the wound and improve wound healing as well. But when supportive care itself is no longer sufficient, and the patient to develop a chronic wound that are extremely painful, and a recalcitrant wound that could not close properly, especially in the area where it's prone to trauma. And that's when I start to consider the next step of a treatment. And when it comes to choices and of a wound, and really also depending on what we're able to have access to some of these treatments as well.
Yeah. And as you've mentioned, if patients have dystrophic EB, there are two FDA-approved treatments for dystrophic EB. And then for junctional EB, birch triterpenes is FDA-approved for that as well. There are currently no FDA-approved treatments for EB simplex, and we hope that'll change, because that's a whole cohort of patients who at the moment, you're right, we're doing a lot of wound care, wound dressing, multidisciplinary team, and it'd be nice to have treatment for that too. What has been your experience treating individuals with EB with the current 2 FDA-approved therapies?
So our center did participate in the BVAC study. So I fortunately was able to observe some of the patient experience as well. And these are therapy indeed that they help patients in clinical trials and in real world use as well in terms of their wound healing and help many of the symptoms associated. So, we have also discussed that when it comes to symptoms of EB as well as chronic manifestations and damages, I'm looking forward to see that how much impact these neurotherapy will make for patients with these chronic conditions, and whether it will reduce the damages that we see. And I'm hoping that in the future that we'll see outcomes from in regard to some of these longer and chronic manifestations that we have mentioned in other organ systems as well.
Right. And improving wound should theoretically help itch, but I still see a lot of patients struggling with itch. So if we decide to start these therapies, what do you tell individuals with EB or their caregivers or their healthcare providers what they might expect when using it? You say, well, we're going to start a therapy. What do you tell them the next steps are?
These therapy do have to be used appropriately, adequately. For example, that we talked about many of these open wounds are prone to have chronic bacteria colonization and infection. If you're using the treatment, without recognizing that using these treatment on the EB wound that's already colonized or infected, obviously is not going to work. And so having that kind of and supportive and access to a dermatologist with experience of assessing these chronic wounds can be very important at the beginning of the treatment. And patients do need to recognize that they need to continue with the other supportive care as well, and wear the appropriate clothing and using the appropriate dressing and to protect these area is still very important. You mentioned about self-injury behavior from itch, and that's definitely a big part of it. We do provide supportive care. And, I do address these questions with patients and family as well. And where, we don't have time during this podcast, but there are also a lot of really exciting advancement and development in the area where for inflammatory skin disease and itch as well. A lot of neuro-targeted therapy have developed personally, and some of my colleagues have tried some of these treatments to reduce itch. So once they start the treatment, if we can also combine with anti-itch treatment to reduce and minimize self-injury, and can also result in much better outcomes.
Yeah, I totally agree. Circling back to the conversation with patients, I found, especially adult patients, they may not have had genetic testing. So they may have had a skin biopsy that is consistent with EB, but when you want to start these therapies, it's important to have the genetic testing. So then it's just explaining this to patients who often aren't quite aware of why you're doing that. And then once the genetic result is back, then highlighting that a process gets started with us, and usually with our EB nurses, with these companies to try to get the medications to them. I'm acutely aware of saying that we're not actually curing your EB, we're just trying to improve your symptoms, the wounds, etc. So that's a really great summary, Dr. Teng, of what the current treatment landscape is. And it's so exciting that we now actually are starting to get therapies available. So we've kind of touched a little bit that EB simplex, for example, doesn't have an FDA-approved treatment. What are some of the other gaps within the treatment landscape across EB? And what are some potential solutions? You kind of highlighted itch a little bit, and there are some treatments, as you mentioned, for other conditions that are itchy that we're utilizing in EB. Perhaps you can talk about that or any other gaps in the treatment landscape.
Yeah, certainly. I'll be happy to. And thank you so much for mentioning about the lack of genetic diagnosis for many of the adult EB patients. And with these newer therapy that are available, oftentimes patients should have access to free genetic diagnosis as well. So, if your patients are not aware of this, and please reach out to one of the EB centers, and they can help provide the access and resources for patients to get a free genetic diagnosis. And now, other gaps that's currently that we're focusing on is fibrosis, and is another big problem in EB as well. And we know that scar tissue development is very, very fast in these patients, and that's an area still be investigated. And whether this is due to inflammation or some other cause, but because the scarring and the fibrosis, and people or affected individual lose the use of their hands and fingers very quickly, and because of the scarring, patients could lose their vision quickly and lose their ability of swallowing. Esophageal dilatation is a common procedure, for instance, performed in patients with a dystrophic EB. And you also mentioned the EB simplex patients, and we really cannot overlook that particular subtypes. And although the current literature suggests that the EB simplex, if you get online and search for it, it seems like it has a lower prevalence of frequency. That is probably largely due to underreport, and it is more prevalent than dystrophic EB patients. These patients don't have a treatment and therapy at all, and they have a different issue. And many of them, for example, have a significant blistering in the weight-bearing area, like their feet, and because their feet are affected so severely. I met many of these patients actually at the EB conference recently in Atlanta, and they really have trouble walking and difficulty with ambulation because they cannot exercise and walk properly. Many of them have weight issues, and because they can't get the exercise they need. So those are just a few.
Yeah, I totally agree. Well, we're wrapping up towards the end. Thank you, Dr. Teng, for your expertise and your input to this wonderful discussion. You have very nicely summed up EB and the treatments available. And in part one, we discussed more about EB and how it can be very devastating and really affect all activities of daily living in these patients. Now more than ever, it is incredibly important for dermatology practitioners to be aware of EB and the burdensome experience that they experience. Dr. Teng, do you have any parting words of wisdom for our audience before we wrap it up?
We are in a very exciting time, and with all the newer therapy that coming out for genetic disease in general, and especially for EB, and the therapies that have been developed for EB are really proof of a concept, and in terms of advancement and of all the newer approach to address genetic disease and disorders. And so if you have patients with these conditions, please, check out some of the resources and many of these approved therapy newer trials that are being developed for epidermolysis bullosa are listed on DEBRA website, as well as clinicaltrials.gov, and reach out to your local expert. And now in this days, telehealth, remote care, and reaching out to EB expert in your area or across the country is becoming very easy, and there are newer therapy that are available really can make a great impact and change the life of these patients. And so thank you very much for having me today to discuss these exciting development in treatment and landscape.
Thank you again, Dr. Teng, for your contribution to this educational discussion. For continued education on epidermolysis bullosa, please visit www.livederm.org for more information. Thank you.
Thank you for tuning in to this latest educational program on DermDocs, powered by LiveDerm. Stay tuned for more dermatology-focused education coming to you soon.